I think it's a really exciting time for the development of these technologies, because we're reaching the point where we can apply circulating tumor DNA as a biomarker to lots of different stages in a patient's journey with non-small cell lung cancer. There are still challenges. I think you can break those challenges down by the potential application of ctDNA. So if we're discussing circulating tumor DNA as a response biomarker, so can we use circulating tumor DNA to identify if patients are responding to treatment? There are challenges still to establish if a drop in ctDNA is indeed a surrogate for longer term endpoints that are gold standard, like disease-free survival and overall survival. Is the surrogacy of a ctDNA drop the same for individual treatments that a patient might get? So if you see a drop with chemotherapy, does that have the same connotation as a drop with immunotherapy? So I think there's still work to understand that in a translational setting. The challenges for use of circulating tumor DNA as a minimal residual disease biomarker, I think, as I mentioned, there are technical challenges to detecting these very low quantities of ctDNA, and currently the assays that we're leveraging that show accuracy in this setting can be quite operationally challenging to provide for patients, because you have to sequence a tumor, send that tumor off to create a panel for that patient, then apply the panel and get the results back. And when you're talking about very tight timeframes after surgery where you need to make adjuvant decisions, that can potentially be a challenge. But we're certainly seeing progress from assays that potentially could have a faster turnaround time, that don't need that tumor personalization. So it'd be exciting to see where that leads next, to see if we can make things more straightforward. And then on the other hand, you have the more complex tumor-informed assays that are improving all the time. So we saw data this year from Max Dean's team, an assay called PhaseSeq, and Bert Vogelstein's team, an assay called SaferSeq, that are really driving down the limit of detection of these assays that should help lower the false negative rate for MRD detection, so allow us to detect a larger proportion of relapsing patients. So there's a lot of movement in the space where people are trying to address some of the challenges that are coming up, but it'd be very interesting over the next few years to see how things change and what assays emerge as clinically important.